Hi, welcome. I want to really quickly thank you for watching this video on new concepts in pain. My name is Kevin Lulofs McPherson. I am a physical therapist or physiotherapist by training, and I am also fellowship trained as well as board certified. So I've spent a lot of time both treating patients in pain as well as working with other providers that treat patients in pain. And I too have suffered from my own problems with both chronic shoulder pain and chronic hip pain. And you know what? It doesn't stop me. And I'm going to really go over in this lecture, this video, reasons why it shouldn't stop you as well. So first, some objectives for you. Pain, it's an epidemic, and I'm going to really speak to that in a sec. But we also have a traditional model of pain, for better or worse, that's based off of pathophysiology or seeing nasty stuff, specifically with x-rays and MRIs. And we're going to see how that's really failing. And then I'm going to propose a new model, and to be honest with you, it's not that new. It's well over 20 years old at this point, but it's just really poorly accepted. And it's poorly accepted predominantly because it's complex. And lo and behold, we're complex creatures, so it shouldn't be surprising to you. But I hope that this video, in general, will give you a better idea about pain and also give you some thoughts about the future. Now, my audience for this one is going to be both people in pain as well as clinicians, so you'll hear me kind of bounce back and forth, and I apologize for that. But bear with me as best you can. So first, let's come to grips with this. Pain, it's a global problem. All industrialized nations are dealing with a large, tremendous amount of population that have pain. And we are consistently failing in the treatment of pain. And I'm sure the first thing that you're going to ask is, well, do you have proof of this statement? And yes, I do. First, let's look at prevalence numbers. You have to have an idea of how many people we're dealing with that have pain before we can start speaking to this problem. So first, just over the last 3 months, about 3 in 10 people are suffering from low back pain in the US. About 2 in 10 when we look at knee pain, and a little bit less for neck pain. That's just over the preceding 3 months. Now, if we look at chronic pain, this is going to be pain that is either recurrent, so it comes and goes based off of somebody doing something that they know is going to set their back off or something like that. It also is composed of a group of individuals who will have a persistent pain in an area of the body. So it's always nagging, there's always some sort of pain. And then the final group that I really hope we can figure something out for is the widespread pain. This is people who have pain across all sites of their body all of the time, often referred to as fibromyalgia. If we group all of those together, all of those 3 subpopulations together, you'll see that roughly 40% of industrialized countries are dealing with one of those 3 different problems. And that's a huge number of people. We're leaning towards nearly half of our population across these countries that are dealing with this problem. We, in the US and even abroad, but these numbers specific to the US, are pumping a lot of money into the treatment of pain, but we're also losing a lot of money when we look at lost wages. And that's what this slide speaks to. You'll see the number 1 category at the top is persistent non-cancer pain. That's going to be chronic musculoskeletal pain, a few other ones, but for the most part, chronic musculoskeletal type pain. $560 billion, and that's a low number. I believe the top number was somewhere around $630 billion. Cardiovascular disease is half of that. Neoplasms, the other ones on this slide, you add them together and they're still going to be less than what we're putting in the treatment, or at least trying to treat, and then all of the lost wages that we suffer from in comparison to chronic pain. It's nowhere close. But here's the sad part. If we look at everything besides persistent non-cancer pain, we're succeeding in treatment there. People are living longer with cardiovascular disease. More and more people are surviving cancers, and you'll see more and more people are surviving with those other diseases listed there. But are we really getting the same results with all of the money that we're pumping into persistent pain? And the argument is no, we're not. So first, where's that money going to? And the money is predominantly going to increase the amount of medicalization, which means the number of treatments, the number of diagnostic tests, the number of things that we do to people who have pain. And you'll see that here, the number of visits to a physician for back pain has steadily gone up over this period of time. If we look at interventions, steadily they've gone up for Medicare, which is our retired population in the United States, gone up over this set period of time. Epidural injections, so spinal injections, again, going up over this period of time. If we look at surgeries, this is the scary one, surgeries over a long period of time. A huge number of people getting discharged after having a spinal surgery done, of which there's been a lot of evidence coming out more recently. There's been a good quality paper talking about how it just needs to be retired. It needs to be put down. We need to no longer be doing spinal fusions for persistent chronic pain. But again, the number goes up. So we are seeing these people more and more. This is where a lot of that money goes towards the treatment of chronic pain. Now I come back to the original question, are we getting better outcomes based on that? And that's what this slide speaks to. No, we're not. We are not getting better outcomes. If you look at this, all of these different lines represent different types of reason to be on disability or Social Security disability, of which you see a flat line for almost all of them, or even a decrease or dip in the line, with the exception of one clear one that goes up, 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 and up, and that's musculoskeletal and connective tissue. This is going to be our chronic pain population. They are getting worse despite the fact that more and more people are going to the physicians. So if more people are going, we're spending more money on it, and we're getting worse outcomes, you have to say we're doing something wrong. So what could the problem really be stemming from? And if you look at the research, we're not good at diagnosing pain, and we're not diagnosing it correctly because we're not looking at the right things. Now, what have we been looking at with the objective measurement of pain? So how do we measure pain? Typically, it's going to be somebody getting an x-ray, or it's somebody getting an MRI, where you see things like osteophytes, sclerosis, you'll see edema in the bone, all of which are objective things that you can see on an image. Well, if the average person goes in to see a healthcare practitioner, usually these are the mechanisms by which we explain the person's pain. But there's problems with that. First and foremost, all of the different things you see on imaging typically get worse or become more prevalent as we get older. This data shows the populations really subgrouped, and it's all looking at the number of pain related to arthritis across different groups of population age-wise. Younger, not a lot, not surprising. Older than the younger groups, the middle group, pretty high. The percentage of people who have arthritic-related pain goes up, not surprising. But now we have a drop-off. The older people have less pain per person than the mid-group. And that doesn't speak well to our historical markers for identifying pain objectively. It means that those images are not 100%. They don't make sense. If we get more specific and not even look at arthritis, but if we just look at pain, neck pain, lower back pain, pain going past the knee, you'll see a nice trend of which you either have this bell shape to it. So again, the pain is worse number-wise. More people have pain in their middle age group than the top age group. Or it flatlines and stays about the same across the board. There is not a consistent increase in the number of people reporting pain related to their age. And that says, again, our objective measure being an image is not very good. So now I'm going to provide a last little just dying thrust into that argument that we need to be looking at images, MRIs, x-rays, and whatnot. This data has been composed by the author listed there and very kindly put together very well by Adam Meekins for the number of people, the number of different nasties that you see on imaging, both in people with pain and without pain. And you'll see that blue to green. So with pain, without pain, it's nearly the same across all of these groups, whether or not you have pain. So all those things that we've been looking on images, that doesn't really tie into whether or not you feel pain. Let's look at another area of the body that really tends to freak people out, and that's back pain. Here you've got the age at the bottom, you've got the percentage of findings, and then you have the different findings. So disc degeneration, you'll see that as we get older, the percentage of findings of disc degeneration go up. Now I'm going to point to you to the more important word, or most important word on this image, asymptomatic. These are people who have no pain whatsoever. And again, trend is up. They go up, up, and up despite the fact that they have no pain. So if these are not the literally the last fork in that argument that we need to be looking at imaging specifically for musculoskeletal pain, I don't know what is. So what exactly is degeneration in the body? Well, I'm going to put to you an argument that was put to me by Tim Flynn, another physical therapist, and that's we have seen each other age. Whether you believe in evolution or not, we have been able to look and watch each other age from the outside for a very long time. We've seen our grandparents get older. We've seen our parents get older. You see wrinkles come on. You see white hairs come on, all of which is considered normal. What we haven't seen, because we haven't had the technology until the last couple of centuries, has been what's going on the inside of the body. There is evidence that says that these different things that we see on the image that we have historically related to the intensity of pain really are nothing more than gray hairs on the inside. They're normal parts of aging, and they're not related to the intensity or the occurrence of pain as strongly as you think. So I've talked a lot about degenerative change. I know some of you guys are thinking, well, my pain started with an injury. I had an injury occur. And this is where things get really complex and really started to push out that boom in the research on trying to figure out exactly how pain works in the body. So I'm going to show you a couple videos on this, and I want you to tell me which one you would expect to hurt more. Here's the first video. Good, I'm going to credit Saving Private Ryan for that footage. Here's your next video. Good, think to yourself, which one hurt more? Now here's the crazy part. When you talk to individuals who have suffered catastrophic injuries during battle, there is a very large number that felt no pain whatsoever. Whether you want to attribute that to adrenaline or whatnot, they didn't feel pain despite the fact that they had a huge injury. Now we go with the other side of the coin where you stub your toe and there's nothing going on. That thing hurts like crazy. Let's add an even more severe life-threatening injury, the paper cut, where absolutely nothing's going on more than probably work that you don't want to be doing anyway. Sure enough, that hurts as if you're going to die at any moment. But you haven't caused anywhere near the same level of catastrophic injury as you did if you were to suffer from an amputation. And this is what got people thinking and going back and forth and saying, wait a minute, this whole idea of it being as simple as seeing either a degenerative process or some sort of tissue injury, and that being related to the intensity of pain, so the more injury, the more pain, just is non-existent. It doesn't work. So we need to start looking at things differently. Now, just in case you are the person who created the video on the right, please shoot at me an email. I searched left and right for the author to give him credit. I just can't find it. So if you know him, let me know and I'll change the video for that. So what other proof do I have that pain is going to be more complex than the injury or the degenerative process that's seen on image or through examination? And that, my friends, is really my bread and butter, what I do for a living. And that's looking at how conservative care, where there is arguably no change to the disease for certain, is as successful, if not more successful in some cases, than surgery, a intervention that is specifically designed to change the disease that we see. And you'll see that we go from the shoulder to the back to the hip to the knee, across the board. We have the ability to see significant improvements despite the fact that the person still has knee arthritis, still has spinal stenosis, still has all these nasty things. But they have less pain and they have more function. So if not for the disease, what variables do you think could be possibly related to predicting the intensity of pain? So predicting this person should have more pain than this person. And we know that the disease doesn't work too well for us. What do you think it is? Well, I'm going to tell you what some of it is based off of the research. So this group went through and they took people with knee pain and they went through and they did assessments. They included x-ray, they looked at their age, they also looked at different variables, including psychological variables. And sure enough, there was a larger intensity of pain with some of these variables. And I'm going to put them in order for you so that you can get a good picture of how complex the intensity of pain can be. First, the number one predictor of how intense somebody's pain is with knee pain was the quality of life related to the lower body. That makes sense. If your knee hurts, you can't do quite as much, so okay. Your affect, just your overall belief in how you feel about your pain, was predictive of how intense your pain was. Depression. If you were very depressed, you're going to have more pain. Next one, quality of life for the upper body. Now we're getting out of the lower body, but we're still looking at a metric that is related to how you feel about your quality of life. Fifth one, finally we're getting to the image. The x-ray, after even upper body unrelated area has been considered, we get into x-ray. Now to tie on to an earlier point, third to lowest predictor of your pain intensity was age. Just ties back to the previous statements. So here we see that there is a psychological component. Now I don't want you to jump off the deep end and say, okay, this guy's saying that my pain is all in my head. I'm saying that there are physiological functions that change in your perception of pain based off of your belief structures. Psychology drives physiology. Physiology can also drive psychology. So the mind-body thing, you can't ignore it. Not anymore. In fact, if we look at predictors of who is going to do well and recover from pain and who has got more risk of suffering from persistent pain, going from a new onset of pain to being more chronic, the best factors out there have nothing to do with the physiology on that macroscopic level. And that's what I'm talking about with the imaging. So the imaging and all that stuff is less predictive than these psychological variables, of which you have depression, anxiety, worry, fear avoidance, which is the avoidance of activity because you're fearful that it's going to hurt. And then your coping ability, being able to deal with your pain. All of these variables are much more predictive of what your prognosis is or how well you're going to do in the long run than what any image could possibly tell you. So what am I saying? I'm basically telling you that pain is not purely anatomical. What you see in an image, not so good. It's not always reflective of the damage. It's complex. And I'm going to get into that a little bit in a few slides, but I want to really tie in that even though there's a psychological component to it, there is a physiological component. But that physiological component is microscopic. It's not something that they can test for when you go in to see the physician. So that is the next portion, and really going into that is, how does pain actually work? We used to think it was this top picture. You put a pain stimulus there, be it a fire on somebody's toe or you cut somebody, and a little cut was going to send a signal up to the brain, it hurts. A bigger cut, a bigger signal to the brain, it hurts more, and so on and so forth. Now, in this century, with all of the research that has been done, we know it is still somewhat a little bit of this, this stimulation coming in, but it's also going to be the brain taking that in context. Context does that include your prior experience with that pain, whether you're paying attention to the pain or not. I'm sure some of you who are watching this who have had a persistent pain, if your brain was busy trying to get something done, or you were handling a stressful situation, or you were engrossed in a book or something like that, you'll notice you have less pain. It's not because those pain nerves turned off, it's because your brain decreased the emphasis that it was putting towards assessing that signal. So you weren't feeling it as much. The mood, your mood, we've already discussed, can change your sensation of pain. Neurochemical and structural changes. You can put all of these into a nice little loop and group them together because they are all interrelated. You can't separate one from the other. So it is very much more complex. The reason why it's complex is because it's learning. A fancy term for learning is neuroplasticity, or one way of learning is considered neuroplasticity. And this is how we go from an acute injury to a more chronic injury. And in this case, we've got these different things happening in the spinal cord. So this is the spinal cord here. These are nerves coming from different areas, in this case from the arm. And you'll see that when a pain signal is sent, it kind of goes into the spinal cord. It drops off some little chemicals into the junction between this nerve, and that signal gets sent over to this nerve, sent up to the brain. Brain says, okay, let me make sense of this information and determine whether or not it's important. Now, with persistent pain, where you become sensitized, what ends up happening is that you have a loss of these interneurons that are supposed to turn off. They're supposed to shut down some of this signaling that's occurring. You also have an increase the amount of chemicals that are being released to send that signal up to the brain. So you basically have a whole bunch of changes that make it easier for the signal to be sent to the brain that, hey, I've got pain. And if it's easier to get up there, there's a good chance that the brain might start paying more attention to it because it is learning that pain. Not only do we have that increase in transmitter stuff, but now we have all these other things that happen. You'll see this WDR, that stands for wide dynamic range. This is actually a type of nerve that is more responsible for transmitting information about pressure. So if somebody's giving you a little bit of a grip on the arm, it senses that. What we have seen is that with sensitization, with learning, you basically start to build up little connections from nerves that were previously only associated with pain type signaling. They start to really synapse and they start to talk to these different wide dynamic range nerves. And now all of a sudden things that were supposed to only be pressure sensations are also being sent to the brain as a pain signal, of which it still is making a determination whether or not it needs to pay attention to that. But if you've got more ease with the signal going through it with its traditional route, and now you've got more nerves sending that signal up to the brain because these have been repurposed, it's no wonder that people are having a harder time when they get to that chronic range. It's because physiological things have changed. You have that change that cannot be seen on an image that is leading to some of the symptoms that people are dealing with. So in general, our big framework that's boiled down to one of the best sides I've ever seen, and that's coming from Ron Melzak, is going to be this one, where we have to take into account the cognitive related brain areas. These are the different lobes or cortices and whatnot in the brain. And they're going to really have a big influence on what goes into the body's perception of itself, which is the body self neuromatrix. That in combination with the signaling I just went over, as well as just the way that your body is responding to its current level of stress, anxiety, depression, those different things that I mentioned earlier. All of that is taken into a jumbled mess and it's shot out as an output of which you can have pain perception. You can have actions where you try to cower or move away from the pain stimulus. And then of course here is our further physiological changes that occur. So this is by no means simply a matter of, well, it's all in your head. It's a matter of, it is all in your head, but it's physiological changes that are occurring. It's not as simple as A to B. So are you in chronic pain? If you are in chronic pain, probably the next step that you're thinking of, well, I've learned all this physiology. I now know that a lot of the images don't tie to me or aren't related to me. What can be done? And there's research on that, and that's something that I'm here to help out with. The best thing that can be done is exercise participation, getting moving. You want to get moving. And I'm sure the next thing you think of right after you saw this slide is, but that hurts. Well, first, remember, hurt doesn't equal harm. If we go back to the regenerative process, you get older, you have more degeneration, but you don't necessarily have more pain. If you have a catastrophic injury, there's a fair chance, depending on the context, you might have less pain than if you have a paper cut. So hurt doesn't equal harm. Now, what we're looking at here is we're also looking at a problem that we have with your perception of pain. You're living in the here and now. So if something hurts now, your tendency is to want to change your behavior and not do that anymore. What we need to do is start to dampen down the nervous system and change some of those things that have happened in the spinal cord as well as the brain. And we do that by exercise. And over time, you're going to have a decrease in the pain that you get, or at least more control over the pain you get with activity. And that's what I'm talking about with a decrease over time. And then the next thing is we want to avoid flares in pain with exercise. So that means you want to do exercise, but you don't want to do so much exercise that you can't do anything for the next 4 days. You want to do enough exercise where you're stimulating the system, but you're not laying in bed afterwards. But the thing is that these flares are going to happen when you exercise, but you shouldn't fear them. When you have a flare, it's a false alarm. The brain is overinterpreting those nerves. That goes back to hurt does not equal harm. So you want to play that line, but recognize that if you jump the line and have a significant flare in your pain, it's nothing to worry about long-term wise. And the evidence resoundingly speaks to that. So if this has caught your attention and you're sold, you know that the old model doesn't work and you want to learn more about the new model, please feel free to reach out to my website or reach out to me through email or through the contact points on the website. Again, thank you for listening in. Bye.